This group of lectures or group of slides goes with acute and chronic renal failure. So we're going to talk about acute renal failure first, and that means that the person has normal function to their kidneys, or they could have some of the beginnings of renal insufficiency, but are experiencing an acute rise of creatinine and an acute decrease in renal function. And those reasons can be divided into three main reasons. Pre-renal causes, so the problem has to do with flow into the kidney. Post-renal causes, so the problem has to do with the backflow of urine, or a problem inside the kidney itself. So pre-renal causes of decreased filtration, because that's what happens. If the kidneys aren't working for some reason, if there's an increase in urinary creatinine, that means that there's evidence that the kidneys are not filtering the blood properly. So why would that be? Pre-renal causes would be that the kidney was never allowed to filter the blood to begin with because there's not enough fluid getting into the kidney itself. So do not confuse this with chronic renal disease. A person could have a low-level problem with flow into the kidney because of hypertension or diabetes or something, which is making their renal function slowly increase, their creatinine levels slowly increase, and their renal function slowly decrease over time. But acutely could have a decrease of flow into the kidney because of dehydration, so there's less flow from the renal artery into the glomerulus, because of heart failure, so the fluid is stuck in the venous side of the system and isn't being pushed forward by the heart because the heart is faulty, or because they got some kind of medication that altered perfusion of the kidney itself. So there's decreased perfusion of the kidney. So how would I know that that's the cause? Well, obviously the rise in creatinine doesn't happen in isolation. There's other patient symptoms. So you would have patient symptoms that correspond to shock or some reason why they would have some kind of infection that potentially would decrease blood flow to the kidneys. Perhaps they're super dehydrated. And so that makes sense that there's decreased filtration because there's decreased blood flow into the kidney. The other thing you can do is evaluate the BUN to creatinine ratio. So I'm expecting that the creatinine level will increase. So say it's usually 1 and now it's 2. That qualifies as an acute rise in creatinine, but I'd also expect in many of these instances related to acute dehydration especially, that's really showing me that there's a decrease in the amount of fluid, which would very much increase my BUN quite a lot. So my BUN might be, 60 or 70. This ratio is very wide, meaning there's a big difference. It's actually a 1 to 30 ratio. I would expect the ratio to be higher in this kind of instance, as opposed to an intrarenal cause, which we'll discuss in a minute. So this BUN to creatinine ratio could also help me evaluate it. And anyone with an acute rise in creatinine should have their creatinine and BUN evaluated together. So please put stars around that. 1, because it's going to be on the exam, but 2, it's also part of the final assessment because that patient also has an acute rise in creatinine. So I could have decreased filtration of fluid, decreased kidney function, evidenced by an acute rise in acute rise in serum creatinine, because there's an obstruction to the flow of urine. So say renal artery is perfused as best as it normally is, it's at its baseline. The flow into the glomerulus is at its baseline. We've created hydrostatic pressure. we're trying to favor filtration. However, if we're not allowing the fluid to leave, that's been created to leave the system, there'll be a backflow of fluid. And pretty soon, the hydrostatic pressure inside Bowman's capsule increases. And then the force doesn't favor filtration anymore because the fluid level is so high here. So creatinine will increase. And that could be because of an obstruction to the bladder outlet or obstruction of a ureter. So there's many different things that could cause obstruction to the urinary tract. Any kind of anatomical issue, so congenital issue, stones, pregnancy, the presence of the fetus can block the ureters, just the extra pressure on the ureters and bladder. Benign prostatic hypertrophy is a reason to have an outlet obstruction or a tumor in the prostate, scar formation, neurogenic disorder that doesn't allow for bladder contraction, therefore doesn't allow for urination, could cause a backflow. Any of those things could cause it. The damaging effect of renal obstruction or urinary obstruction is that you're going to have backflow and stasis of urine. When urine is static or it's just sitting there, you have an increased risk of infection. That's one of the big things. The back pressure will also interfere with the blood flow to the kidney and could destroy the kidney. So the picture on that slide, and for this, we're on slide 25, shows what's called hydronephrosis. So the renal calyx starts to get really big because it's full of the urine that can't kind of come out. That ureter would also be expanded. And you can see on that picture that means there's increased pressure inside the kidney capsule itself. It's going to decrease the ability of the kidney to be perfused. So that person, eventually, that obstruction has to be relieved. One, to get rid of and allow for the body to filter its wastes, but two, to preserve the kidney itself because it could start to become ischemic. So manifestations obviously would depend on what is the ultimate cause of the obstruction of urine outflow. So again, I would have an acute rise in creatinine, which I would evaluate with the BUN, and again, I'd have a very wide ratio, again, greater than 15. I might have the same BUN and creatinine numbers as I did with the pre-renal person. The cause and the site of obstruction would determine where I have my pain. I might have urinary tract infection symptoms. If I'm pregnant, obviously that's more obvious. If I have acute pain in the ureter that radiates down to the pelvis, then it could be a stone. So the other types or parts of the history will tell you that. The next slides are letting you know how kidney stones develop. So that picture there is obviously a very blown up picture showing you the beginning of the stone being formed inside the urethra. That's what that B is pointing to. So a stone is a crystalline structure that develops because of components in the urine. And something inside the urine itself promotes the development of crystals, promotes solute to precipitate. And it starts with a formation of a nidus, which is really just the start, which is sometimes called Randall's point, where the crystals start to come together. So in the nephron, because these can develop in the nephron and collect in the ureter, or in the ureter itself, or wherever it decides to develop, these little pieces of crystal will start to form. And then this, where it starts, it'll start to get bigger and bigger. And it could be a stone that's created in the kidney itself and then leaves into the calyx and down into the ureter and gets stuck there. As people can form multiple stones over time. And then in their urine test, I might see the leftovers of urine casts and crystals because they're starting to form those kinds of things. So factors that influence is the concentration of those crystallized components in the urine. So say maybe I'm increasing my intake of purine, which becomes uric acid. So I've increased the amount of uric acid in my bloodstream and could increase the amount of uric acid in my urine. That might start to increase my possibility of forming uric acid stones. I have more, or I have a decreased stone inhibition factors inside my urine. So the normal crystals that could be in there, phosphorus or calcium, can precipitate because I don't have inhibitory factors. So that next slide is showing you that crystals can form, but that should be inhibited by other counter-regulatory crystals or stone inhibitors like citrate or magnesium. If I have a stone that develops and I'm lacking the inhibitors, then I promote crystallization, and those stones can be made of different things like calcium and phosphate and urate or uric acid. And if I don't have inhibition, then the stone can get bigger and bigger. And the larger it gets, the more likely it's going to cause a problem. So that's why sometimes people are encouraged to try to collect the stone, because if you can see what the stone is made out of, you might be able to stop it if they keep having stones develop. The other reason to develop acute renal disease is something called acute tubular necrosis, which means ischemia and cellular destruction are occurring in the tissue of the kidney, the nephrons themselves. And so why could that occur? So it could be, maybe it developed because of a pre-renal issue. So the person started to have decreased blood flow into their kidney. Maybe they developed a clot. So the clot in the renal artery, eventually, there's going to be decreased filtration, and we're going to have an increase in creatinine, but it might actually further increase the creatinine if we start to kill off the kidney. Now we've got an intrinsic issue because the kidney itself is necrotic. Perhaps we've exposed the kidney to nephrotoxic drugs. The person had too much ibuprofen, which can lead to renal necrosis. The person got a hefty dose of uterine renal contrast, something like that. Or there's an obstruction because of a transfusion reactions. We have increased red blood cells in the nephron, or increased immunoglobulin or muscle globulin in the nephron, something, an increase in inflammation or infection in the glomerulus itself. All of those could be a cause of renal disease that's from the kidney itself. Again, we would have to look at the story of the patient and their blood tests. So one of the causes of acute glomerulonephritis is prolonged strep infection. Immune complexes get stuck in the glomerulus, and so there'd be a story that goes with that. And I would see a BUN and creatinine ratio that are very close together because both of them are very high together. Because the issue isn't related to fluid at all. The issue is related to destruction and necrosis of the kidney. So the story should fit. Person has baseline renal dysfunction and then was given a nephrotoxic antibiotic to help treat that, so they had baseline kidney dysfunction, they had an infection which promotes dehydration, so they're already at risk kidneys, and then we gave them a medication that could potentially cause tissue injury to the nephrons. So you can have a mixed picture, certainly set somebody up to be more sensitive to that. So the hope is that if you see an acute rise in creatinine, that you figure it out and fix it so that you can progressively help the patient recover. Because there's an onset, the initial injury, and then there's going to be a marked decrease in glomerular filtration until the underlying problem is taken care of. And then you want tissue recovery to take place. That's the phases of acute tubular necrosis. The next section we're going to talk about is chronic renal disease. So chronic renal disease is a decrease in renal perfusion or decrease in renal function that occurs over time. So it's a progressive rise in creatinine because we're seeing a progressive destruction of nephrons over time and therefore decreased ability to filter the blood over time. So it starts as a continuum. Decreased renal reserve leads to renal insufficiency, which ends up being renal failure and then end-stage renal failure. The progression of chronic renal failure can be, you can calculate that or look at that by looking at the GFR, which is the glomerular filtration rate, which is much more sensitive to creatinine than to creatinine. And that's how we define it. And what we see is once we get to a GFR that's less than 15 milliliters a minute, you're going to need renal transplant or dialysis because you're going to end up with too much metabolic waste in the body and too much fluid. Common causes, as you'll see, those first ones, especially hypertension and diabetes, is a decrease in flow of blood into the kidney over time, which occurs with both of those conditions. Polycystic kidney disease is a genetic disorder that promotes cyst development, which we'll talk about in a little bit. Chronic obstruction of the urinary tract over time. Some types of glomerular nephritis are actually chronic, different autoimmune disorders and cancers. So cystic disease of the kidney means that you have these fluid-filled sacs in segments of the nephrons, and that will start to cause dilation of nephrons. So what happens is person starts to form cysts in the cells of the nephron, and that's where the genetic problem comes in. A person could develop a solitary cyst or one or two cysts in their kidney. It's actually not completely uncommon to have one cyst that someone finds incidentally because they did a scan of your abdomen for something else. It's the multiple cysts or the easy cyst development that's the problem. So once you obstruct this nephron tube because of the cyst, you're going to end up with an increase in intratubular pressure. The kidney itself can only expand so much. It's in a capsule. So anytime you add volume to it, you will push onto the capsule, which will cause pain for the patient. And it will increase back pressure of flow out of the nephron, and the backflow will change filtration pressure for the kidney itself. So you develop these fluid-filled sacs, they start to obstruct the nephron, increases intratubular pressure, so it's harder to filter. More cysts and more of this happening in many nephrons will decrease renal function. And the reason is that there's genetic alteration to the cells of the basement membrane and the epithelial cells of the nephron itself. So a simple acquired renal cyst, most of the time not something to worry about. That can happen. Polycystic kidney disease, where a person has multiple cysts and decrease in function of nephrons over time, as well as an increase in pressure in the renal capsule causing ischemia, will have pain and decreased renal function, and it is one of the reasons to need dialysis or kidney transplant. And someone can be born with that, which you would see immediately, especially if it was a dominant, or you can notice it over time. You can have a chronic disease in the glomerulus that causes what's called nephrotic syndrome. So there has to be a change in where those blood vessels are, the glomerular capillary, and the Bowman's capsule where those slit pores are supposed to be. What can happen is these tissue cells of Bowman's capsule can break down or change. They could get more fat inside them, lipid deposition, or there can be destruction of the basement membrane between the blood vessel and Bowman's capsule, which allows an increase in protein in the urine. And that's how people generally detect they have nephrotic syndrome, is because they have an increase in proteinuria. So those are the primary causes: minimal change disease, membranous glomerulonephritis, and focal segmental glomerular nephrosis. Those are primary causes. People can be born with those. Secondary causes, the most common secondary cause of nephrotic disease is diabetes. So membranous glomerular nephritis is thickening of the glomerular basement membrane because of deposition of immune complexes. So it's thought to be an autoimmune disorder, which will increase permeability of the glomerulus, and you'll lose plasma protein. So if we have this basement membrane right here, and we have those podocytes that are part of Bowman's capsule, and then we have the vessel that's here, if for some reason a patient develops an autoimmune disorder where there's antigen and antibody complexes in that area, that those antibodies trigger the activity of cells of the adaptive immune response. So that means they're going to end up causing tissue destruction in that basement membrane, which means we can have increased filtration of larger particles like proteins and red blood cells, especially proteins. So if you're losing a lot of protein in your urine, the urine itself changes color, odor, gets more frothy, and you're going to be losing more protein in your serum, which means a decrease in plasma oncotic pressure and edema. Oh, that's bad because I said, what the fuck? I'm recording that too, so I'll have to edit this one. Oh, that'll be awful to hear myself yell at you guys. Okay, the secondary cause is diabetic glomerular sclerosis. So you start to incorporate sugars and defective synthesis of the basement membrane because of elevated sugar over time, which will then again allow protein to leave. And so what you notice most is that there's a hypoproteinuria because the patient is losing proteins in the urine. So clinical manifestations of chronic renal disease have to do with everything that is lost because of all the jobs of the kidney that we talked about before. So we're supposed to be getting rid of protein and nitrogenous wastes from protein metabolism. That's going to build up in the system. Increased protein in the system changes mental capacity quite a bit. People get fatigued, they have altered level of consciousness, they can become more confused. It changes, obviously, their fluid balance, they retain more fluids. That means edema with a decrease in proteins, potentially. So alteration of water balance, alteration in electrolyte balance. They usually have an increase in phosphorus, an increase in hydrogen, an increase in potassium with less or diluted sodium because of the increased fluids. If there's an alteration in calcium and phosphorus, there can be changes in the bones. The kidney's in charge of production of erythropoietin, which means potential anemia. Increased fluid changes blood pressure. So the symptoms or problems that are related to chronic renal disease are quite a few.